Murali Sai here. Good morning.
I'm Dr. Murali Ariga from Chennai, and I'm extremely happy to participate in the glaucoma symposium at Cochin today. I'm going to share my screen now. I'm going to speak on pearls and pitfalls in perimetry. Perimetry is a very commonly done investigation for glaucoma, neuro-ophthalmology, and so on. In particular, with particular relevance to glaucoma, I think we should understand the finer nuance of perimetry before we start doing it for patients, and then understand the problems and pitfalls which we face during the tests which we do for glaucoma evaluation. First and foremost, you must understand that automated perimetry is a subjective test of visual function. You must have a well calibrated machine which is periodically checked by the biomedical engineers. Patient must be properly instructed, and you can even have a demo video as to how the test is to be done, how to be seated. As you can see in this picture, the height, the chin raise, the forehead. Make the patient comfortable and do a demo before the test is done, and do a trial run so that you get a good outcome when the field test is done. The perimeters must be encouraging because it's a subjective test and sometimes a very uncomfortable test. So encouraging enough to make the patient do the test properly. And finally, when we get the result, you must interpret systematically and not jump to conclusions based on just one or two findings. You use the entire clinical picture for your clinical judgment. A checklist is make sure that the field test which you have in front of you, the report which you have in front of you, is done with some reliability, which means false positives, false negatives, and fixation losses had to be evaluated in the printout. The pupil size has to be of say at least 3.5 millimeters, or if not more. You can even dilate the patient to do the perimetry. The pupil size is important because the thresholds can vary. The refraction and near correction are very important. Make sure that the patient is able to see the fixation target, doesn't have very poor vision. And also the very high refractive errors, you can do the field test with, and FX, you can do it with a contact lens. And for certain machines, you will need the near correction for patient to be able to see the fixation target. And also, you should understand that there's a learning curve, and patients do these tests for the first time. They are sitting for the first time. They will not be able to understand the finer nuances. So give them some time, and always maybe look at the first test as a trial test. Use the second and the third field as a baseline for subsequent comparisons. So this is the field printout, as you can see, and we usually divide it into zones for our understanding. Zone 1 is the patient data, patient ID, age, sex, and so on. Zone 2 is the reliability and the test duration, and you can see the false positives, fixation loss, fixation false negatives, and so on. Zone 3 is the grayscale, which is a rough estimate of what is going on in the visual field. You can use it to explain to the patient and the relatives as to how much of field loss is there, what is going on, and so on. It's not useful for our management generally. Zone 4 is the total deviation. You can see the p values and the dark areas, which indicates actually the significance of the abnormality of the points. Zone 4, total deviation, and the actual as the estimated loss in terms of threshold loss, zone 4. Zone 5 is the pattern deviation, which is more significant for glaucoma than the total is. The pattern deviation tells you what is underlying the generalized depression due to cataract, refractive errors, and so on. The pattern deviation tells you what is underlying. Zone 5, Zone 6 will give you information about various aspects of how the test is done. Zone 6 gives you the VF5, the visual field index, the MD, and the PSD. Zone 7 is the glaucoma ME field test. And zone 8 is the actual thresholds which are measured. So once you have an idea of the different aspects and parts of the HFA, this is the HFA Humphrey visual field printout. The trial lenses have to be placed properly. The patient's chin and forehead has to be placed properly. If the patient is not positioned well, of the full aperture trial lens is not placed properly or decentered, you will get trial lens related artifacts and artifacts due to the improper placement of the trial lens and using different types of powers and so on. Make sure this is all done and understood well by the perimetrist and patient is made comfortable. As I already mentioned, the minimum pupil size could be about 3.5 millimeters, and anything more is comfortable and fine. But make sure that the field test is done every time with the same dilated pupil. If you're doing dilated pupils, the patient can be dilated without angle closure, with no contraindication for dilatation and so on. So perimetry can be done dilated provided there is no contraindication for dilatation, but every test must be same pupil size. Eyelid artifacts like ptosis, drooping eyelids can be corrected by taping up the eyelid when you do a perimetry. And of course, as I already mentioned, that rim artifacts due to trial lens and improper patient positioning also results in artifacts. And to know how much of field test to do for a particular person, generally we do the central field. The central 30 degrees actually covers most of the ganglion cells and corresponds to 83% of the visual cortex. So most often with using a Humphrey type of perimeter, you can do the 30-2 or the 24-2 by default. 30-2 or default, 24-2. 24-2 will take less time. The 30-degree field will take more time. So the compromise on time is not an issue. You can do a 30-2 30-degree evaluation. You don't need to do a full field evaluation for most of the clinical situations. What is the difference between the 30-2 and 24-2? As you can see, we are testing more number of points in the central 30 degrees, whereas in the 24 degree, you are testing less number of points, which is obvious. And also you will see that the edge points become more important in the 24-2. It is said that suppose you're having edge points in the 30-2, you will find, so for example, the field example on the left shows you certain borderline abnormal points in the edge of this field. The GHT is borderline. And you can conclude this is a borderline test, reliability is okay, and you tend to ignore this field. But actually, clinically, we have found in this particular patient, there's an RNFL defect. There's something in the optic disc which is looking abnormal. The field is looking borderline. So you go ahead and repeat the same patient's field with the 30-2. You will find the entire field becomes abnormal. The GHT becomes outside normal limits. So the take-home message in this slide is that do not ignore edge points on the 24-2, whereas in the 30-2, the extreme edge points and non-congruent points can be neglected, but in the 24-2, edge points are also important. And when you do a field for an advanced glaucoma, you will find that the central field, including the central part of the 5 degrees of the field is involved, like in this particular patient. The 30-2 showing involvement of the central field. You need to know more of what is happening in the central 5-10 degrees. So which is when you will find that the visual field close to fixation. You will need to do the 10-2 field. And this gives us more information because the number of test points tested in the 10-2 is 68 points with a 2-degree testing distance between points, which is why 10-2 is important when you have visual field close to fixation. So what are the testing strategies available to us when we do perimetry? We have supra-threshold, threshold-related, full threshold, and the efficient thresholds. So efficient thresholds include the commonly performed tests like CETA, the CETA standard, the CETA fast, and in the octopus perimeter, you have the dynamic and the tendency-oriented perimetry called TOP. So by default, most of the machines, the Humphrey machines will all do CETA only. We don't do full threshold, threshold-related supra-threshold for almost any patient nowadays. We only do efficient threshold, CETA or CETA fast. Between dynamic and TOP, I think for a patient who's doing for the first time, I would suggest you start off with the CETA standard or the G dynamic for the octopus. If your patient is well versed with perimetry and does it very well and efficiently, then you can switch to CETA fast. But CETA fast, even though it's a quick test, sometimes patients don't understand and they don't do it so well. The same applies to the TOP also. So I think a standard default strategy for testing would be the CETA standard or the G dynamic. And 24-2 or 30-2, depending on the circumstance you are testing. A 30-2 will take more time for testing. So the time testing required for a test with the 30-2 full threshold is about 14 minutes. The CETA standard will take about 8 minutes. The CETA standard 24-2 takes about 4 minutes, and the CETA fast takes about 2 to 3 minutes. So depending on the patient's ability to test, patient's ability and understanding of previous tests, the perimeter, you can decide which one to do. But if you're given one default test you really want to do almost for every patient in your glaucoma practice, you can probably use the 24-2 CETA standard. If you want to do more or less, you can decide on the strategy and the extent of field to be tested. We'd also have the newer perimetry program called the CETA Faster now, which is the 24-2 CETA Faster. It does it much faster than the CETA Fast as well. This is a good test for people who are familiar with perimetry, and the results are as good as the CETA Fast. Reliability and learning curve, as I already mentioned, a good reliable field is important for us to make it useful for glaucoma management. As you can see on the picture on the left, extensive false positives because the patient has not been instructed properly or has been trigger happy. You do need to give some time and explain the nature of the test, and there is a learning curve in understanding. So make sure the patient's test is repeated. It need not be done on the same day. You can actually give some time and repeat it after a day or two. In fact, you can do one eye today and an hour later you can do the left eye. So, and give some time for the patient to understand. Allow the patient to blink as they press the button, because without blinking, when the patient does, that anxiety of where the next part is coming is always there. So give some time, be patient, give time to repeat the test and then start interpreting. The instruction videos of how to do the test are extremely important. And here you can see an advanced glaucoma showing extensive false negatives. A false negative alone by itself does not mean the patient is unreliable. And severely diseased glaucomatous eyes, you will find false negatives are high. This is part of the disease process. So false negatives alone like this need not be ignored and can be interpreted along with the clinical picture. So is the field abnormal or not? As I already mentioned, a cluster of 3 or more non-edge points on pattern deviation with 1 point less than 1%, a PST or CPST what occurs in less than 5%, and the GHT outside normal limits. Any one or two of these or all three of these are important in along with your clinical judgment and clinical picture to decide is the field abnormal and is the patient having a glaucomatous field and so on. Just that picture of being abnormal and having a statistical abnormality does not mean the patient has glaucoma, as we know that. We need to correlate to the entire clinical picture. And this is the Anderson's criteria, which I have shown you on the slide here. This 3 or more non-edge points applies to the 30-2, no doubt. But the edge points become important on the 24-2, and that they should not be ignored. Is it glaucoma or not? How do we know that? The field pattern should be following an arcuate pattern corresponding to the pattern of nerve fiber loss, asymmetrical across the horizontal meridian, and the field defect is located in the mid periphery in early to moderate cases, and 5 to 25 degrees from fixation. The field loss should be reproducible another time and not attributable to other pathology like an optic atrophy or a macular scar and so on, or a laser scar which is already there. These field defects in glaucoma are usually clustered, localized to neighboring test points, and defects should correlate to the appearance of the optic nerve head. The field defects and the vision is generally not affected in glaucoma. Patient would have 6966 vision, except in advanced glaucomatous optic atrophy, loss of central field due to the presence of cataract and so on. Glaucomatous optic atrophy and macular scars, all this will affect the vision. So disc pallor with a poor vision loss and an arcuate field defect is most likely unlikely to be glaucoma. So central vision, 6-6 vision is the patients usually don't tell us that they have a field defect in glaucoma. If anybody has a vision loss of 360, 660 and you have a pale disc, it's unlikely to be glaucoma. So keep that in mind when you're evaluating the field. This is a classic example of an RNFL defect, as you can see superiorly here. This correlates with the field defect which you're seeing in the Humphrey visual fields 24-2 here. So this kind of classic correlation is simple and straightforward, but you can have difficulty in looking at the field, and then sometimes you will miss it on the disc and the nerve fiber layer examination. When you see a field defect like this and the pressure has been high and you have missed this, you can go back and re-examine the disc and you may find this. So there has to be a correlation of structure and function. You cannot have isolated functional change on perimetry, and the disc and field cannot be absolutely abnormal. So there has to be a correlation. So this is a simple, straightforward interpretation of hemianopia. This is obviously not glaucoma. This is not in the arcuate pattern of the RNFL. So this is classic hemianopic pattern. I think you don't even need an ophthalmologist to tell you. Even a medical graduate could tell you that this is not glaucoma. But the problem would come with the bilateral symmetrical field loss. When you have one single field which looks like this and you have the other field in a different page, you don't keep both side by side. You will not interpret as being some bilateral symmetrical or slightly asymmetric field loss. Make sure you have the suspicion that this kind of bilateral symmetrical kind of field loss, like quadrant anopias, are not missed, and have the suspicion of being able to look at both the fields kept side by side, look for the slight asymmetry or symmetrical field loss. and interpret and see if you need to do a neuroimaging to exclude a neuroophthalmic cause. When intraocular pressure is normal, patient has a vision loss and some other CNS symptoms, don't forget to image these patients and don't miss neuroophthalmic problems. We have all been taught that structural changes usually precede functional changes like perimetry. It is not always so, but generally you will find early structural defects like a notch in the rim, an RNFL defect, a small RNFL defect with a disc hemorrhage here on the picture on the left, and the field is usually normal. This is early because the pattern of testing of the 24-2, the standard testing, sometimes tends to miss all of this. If your 24-2 is not showing it, you can actually do a 10-2 because the testing pattern is more close in the 10-2. This is for so-called pre-perimetric glaucoma. But when you have a larger RNFL defect like this and a big notch in the rim, this is easily picked up on clinical examination, and also the perimetry would show it. The classic example and explanation of pre-perimetric glaucoma and asymptomatic disease is that the nerve fiber layer changes are usually sometimes not detectable, but once it becomes detectable, you can probably pick it up on short wavelength automated perimetry. Standard perimetry shows up a little later, and the visual field change becomes moderate and severe and leads to blindness. This is the so-called changes that happen the spectrum of structure function, and you need to correlate the intraocular pressure, the corneal thickness, the cup disc ratio, the presence of the secondary factors and age and so on. All of these factors had to be kept in mind in the jigsaw of diagnosing and managing glaucoma. As you'll always find in many patients with a structural change, the standard 24-2 field may be completely normal, and you will find this is so-called pre-perimetric glaucoma. But you can go ahead and test what is called, as I already mentioned, the 10-2. 10-2 will sometimes show you an abnormality like this because the testing pattern is closer, 68 points, 2 degrees apart in the 10-2. Swap is also useful, but nowadays we don't do swap, and the OCT has come in, we don't actually do swap in many of our patients. The newer program available in perimetry is called the 24-2C, which has actually incorporated some of the points of the 10-2 itself in the 24-2. And this actually tends to pick up more points than the standard 24-2. It's quite a useful test because we don't need to keep doing 10-2 when the 24-2 is normal. The 24-2C is quite a useful test. So lastly, I would like to repeat that automated perimetry is a subjective test of visual function. I already said that in my first slide. Have a well-calibrated machine, instruct the patient properly, and encourage the patient to do that. It's a subjective test. And lastly, make sure your interpretation of the visual field is in line with your clinical picture. Do not interpret or manage or operate on patients based on just one single field alone. And thank you all for listening.
Thank you, Dr. Murali. You are there?
Yeah, I'm very much here.
Hi, Sai here. Good morning.
Hi,
good
morning.
I was speaking to you initially. I didn't know it was a recorded one. So, great presentation on perimetry as always. As Dr. Lita gets ready with her next talk, we can have a few questions for Dr. Murali. You mentioned briefly about the 24-2C.
Yes.
I don't know, I'm not a very great fan of the 24-2C when in continuum. When you start doing it, it's okay, but do you really find it useful when you look at a series of tests where you want to really look at progression? Sometimes the cluster of points at the central area are more darker in a C sort of program, and sometimes you tend to overestimate progression. Have you felt that way, Murali? And what is your comment on that?
Yeah, I think I entirely agree with you. I don't do 24-2C at all. And I'm using now the Octopus in all my centers. So there we have what is called as the G program, and you have the cluster analysis. So once you have a cluster, we do a cluster trend, and we look at the change over time. So I don't do 24-2C at all.
Any comment? Yeah. Gauri wants to make a comment.
Comes with only the theta faster, and that is not the ideal one for all patients, like Dr. Murali pointed out. So it is a screening. So on a routine basis for the management of a glaucoma patient, follow-up, detecting progression, diagnosing, I would rather do a 24 or a 30-2 initially and a 10-2 if I feel any central testing.
Absolutely. And it doesn't speed up the test either.
Absolutely.
It doesn't speed up the test. And the neurological tests, as you know, whenever we do, whatever we show and whatever you have also shown are all either 24-2 or 30-2 tests. Do you routinely do that old sort of 2-point or 3-point screening test, 120, those tests for a neurological fast screening, or it's always better to do a 30-2 for a neurological test?
I think all neurologists would actually prefer the 30-2 nowadays, and nobody asks for the full field at all. So it's always 30-2.
They have it. The Humphrey has it. I don't know about the octopus.
They
We are not going to be drawn into a debate between octopus and Humphrey with the TG and Murali sitting here. All great fans of the octopus. Yeah,
Sir, Dr. John here.
Lita, you can get.
Do you have any comments on virtual reality perimetry? They are more comfortable for the patient, but how about the reports?
You mean the headset one?
Headset ones, sir.
Yeah, the headset ones are fantastic actually. And we have started using it in our vision centers, peripheral centers, where we can't install these expensive machines. And I do find that if you have an established glaucoma, at least say moderate to advanced glaucoma, the field defect is easily picked up. But for the early screening, the early RNS defects, and many of the early glaucomas is being missed. So for established glaucoma, I think it's okay. For neuro-ophthalmology, it's okay. Bedside tests are okay. But for routine glaucoma clinic, a full established glaucoma clinic, I think that's not the way to go. For peripheral centers, second clinics, screening by the bedside, all this it's fine.
Thank you, sir.
Thank
Anybody in
you.
the audience? Okay.
Yeah. Thank you so much, Murali. We miss you here.